So gastritis is obviously inflammation of the gastric lining. It comes in two main flavors, and that's acute and chronic. Acute is erosion of the mucosal barrier, and it's usually due to something like non-steroidal anti-inflammatory drugs or sometimes alcohol. The special incidences where you can get an acute ulcer and something called a curling ulcer, which is an EMQ favorite, and that's when you have a large amount of burns and third spacing, and then you get sort of a sloughy appearance of the gastric mucosa, and that can eventually lead to ulceration. And then the other one lumped by EMQs is Cushing ulcers, and this is when you have a head injury which raises your intracranial pressure, which increases your vagal tone. You'll remember the vagus nerve is a parasympathetic wanderer of the nervous system, which increases gastric secretions and can cause ulceration. More common is a chronic non-erosive type gastritis, and that comes in two types. Type A, which is in the fundus and the body of the stomach, and that's usually autoimmune mediated, and certain things like pernicious anemia, which is when the parietal cells, which make intrinsic factor, which are used for the absorption of vitamin B12 in the terminal ileum, is attacked. And then there's type B, which is in the antrum, which is usually H. pylori infection. And H. pylori is more commonly found in these places due to lower amounts of acidity. As you remember, H. pylori has got a flagellum and is mobile and lives in the mucosa of the actual gastric bodies itself. There's an H. pylori lecture if you need to refresh yourself about that. So gastric ulcers are erosion of the gastric mucosa. An ulcer differs from just an erosion, as an ulcer goes through both the mucosa and the submucosa down to the muscularis layer, whereas an ulceration will only go just to the an erosion would go just to the mucosa. So ulceration is full sort of thickness, and gastric ulcers have the risk factors of smoking, non-steroidal anti-inflammatories, and H. pylori infection yet again. Now, food makes it worse, as when you eat, it will cause the gastric secretions to increase, and this is why people with gastric ulcers have a tendency to be described as thin smokers with other comorbidities as well, and they have systemic weight loss due to this, and they will end up needing endoscopy to biopsy gastric ulcers, as they do have a malignant potential. My friend who's a gastroenterologist says everyone should have an endoscopy before they die, and this is definitely a case where one will be indicated as weight loss with stomach problems. Could be something more sinister like a gastric cancer, and without an endoscopy and a tissue biopsy, you wouldn't be able to diagnose that with any degree of certainty. So duodenal ulcers are slightly different in mechanism. They have higher rates of H. pylori, almost 90-95% would be due to H. pylori. And this is because you get increased gastric secretions with H. pylori, which increases the acid content, which then hits the duodenum, which tolerates high acidic loads very poorly. And then they do get better with food. They tend to need to wake up at 2 in the morning to have food. And this is because there's a variation in gastric secretions, which are at their highest between midnight and 4 a.m. And that means that your pH of your stomach will decrease as the secretions increase. And then when you eat, you'll have a transient drop of that, as the food will start to neutralize the acidity, and also the pyloric sphincter will close as you eat, and that decreases the amount of acid trickling through to this duodenal ulcer. So people with duodenal ulcers have a tendency to be described as fatter, and they wake up for a glass of milk at night, and that's why they have a tendency to put on weight. If you have an EMQ question, we have multiple sites, ulcers throughout the GI tract, and it's a young person with not too many risk factors, and think of a Zollinger-Ellison syndrome, which is when you have a gastronoma secreting tumor, which can be in either the pancreas or the duodenum, and that's covered in a previous lecture. So duodenal ulcers have little malignant potential, as they're mainly H. pylori in etiology. So the treatment is gastric protection and PPIs to treat the underlying cause if someone's a smoker or a drinker. And then if it's confirmed to be H. pylori, on endoscopy or breath test or urine or blood test, Then triple therapy is indicated, which is a 3-week course of a PPI of your choosing, amoxicillin and clarithromycin. And if penicillin allergic, then metronidazole would be a reasonable choice at this stage. And then, as said previously, if someone's having these problems of weight loss and stomach pain with numerous risk factors, then obviously an endoscopy to make sure there's nothing more sinister going on is indicated. Now, something that is more sinister is gastric carcinoma, and that's almost always adenocarcinoma in etiology. Risks include smoked foods with the nitros in them, and chronic type A gastritis. Okay. Has a very poor survival rate because of early metastases, and you'll have signet rings cells which will be on the histopathology, which will be pathognomonic of gastric carcinoma. Acanthosis nigrans is when you get abnormal tanning of the skin. It's usually in the axilla, and it gives it's not just a tanning, but it's a thickening and a roughening of the skin. And 90% of people with this skin condition will have a malignancy somewhere, and most of the times it will be a gastric carcinoma. Other things which are pathognomonic is a Virchow's node, which is in the left supraclavicular lymph node, and a Cystomary Joseph nodule, which is subcutaneous tissue nodule just over the umbilicus. And these two things mean you usually have a gastric malignancy or intra-abdominal pathology, which for the purpose of the MQs is usually gastric in nature. And the final thing, which is pathognomonic, is a Nuckenberg or Kuchenberg tumor, which is bilateral ovarian metastases. So it's a Kuchenberg tumor will be bilateral and ovarian in nature, but it is a metastases from the gastric carcinoma.